Fine, fine, very much fine.
Long time no see.
Yes, yes, yes.
Suddenly I saw you.
Yes, I
Good,
also
good,
saw you.
really.
It was a surprise for me also. You are there.
No, today evening it was, I mean,
Yes,
I have to
Hello.
take round. There is one
Sir, we
webinar
are
late
live
night
now. You
that I
can
have
start.
just attended one session. Long time I'm
Hello.
not attended.
yes.
Sir, we are live on YouTube. Sir,
Oh,
please start. Thank you.
Oh,
Yeah,
yeah.
we can
Oh,
start.
yeah.
Yes, sir. Please start.
We are just starting in 2-3 minutes. Please bear with us.
Good afternoon, everyone, respected teachers. Today we'll be starting with a neuro case. Um, so starting with, uh, this is a 2.5-year-old female child, first by birth order, born out of third degree consanguineous marriage, hailing from UP, resident of Sivaji Nagar, Govandi, Muslim by religion, informant his mother, came with complaints of abnormal behavior since 7 days, abnormal movement of bilateral upper limb and lower limb since 7 days. Coming to the HOPI, child was apparently all right 7 days ago when she developed abnormal behavior in form of excessive crying associated with disturbance of sleep, agitative behavior, irritability. Child was able to speak to the three words with meaning previously, but since 7 days, the child is not able to articulate words. However, she is able to understand. Child also has abnormal movement of bilateral upper limb and lower limb in form of dance-like movement with writing movement of the hand, choreoathetoid type, lasts for about 2 to 3 minutes, subsides on its own, then reappears after a few minutes. This movement is not present during sleep. Child also has attained neck holding at 3 months of age, but since past 7 days, she is not able to hold the neck in midline. Child was able to sit with support at 8 to 9 months of age, crawling at 1.5 year of age, but currently she is not able to do so. Prior to the above symptoms, 1 week back, child developed multiple discrete vesicular rash over the mouth, hands, and feet, which was initially seen in the oral mucosa and around the mouth, which then progressed to involve the hands and the feet, which was associated with fever for 2 days, which has subsided on medication. Coming to the negative history, there is no history of excessive startle to sounds, no history of excessive sweating, change in bowel habits, no history of fever with altered sensorium prior to the onset of symptom, no history of seizure, no history of trauma, no history of abdominal distension or jaundice, no history of abnormal odor of body fluids or urine, no history of sore throat, cough, or cold. Past history is not significant. Coming to the ANC history, it is uneventful. ANC scans were done, which were told to be normal. Took TT and IFA tablets. No history of any torch infection, diabetes, hypertension, hypo or hyperthyroidism in the mother. Birth history, it was a full normal vaginal delivery. Baby cried immediately after birth. Birth weight was 2 kilos. No history of any NICU stay. No history of neonatal jaundice. Discharge on day of life 3. Child is immunized up to 1.5 years of age, which is up to date. Coming to the developmental history, gross motor, the child has developed neck holding at 3 months of age, rollover from supine to position, from prone to supine at 5 months of age, sits without support at 8 to 9 months of age, crawls at 1.5 year of age, stands with support at 2.5 years of age, which developmental question is 40%. Child currently is not able to sit without support, no rollover, no neck holding, and the developmental question for the gross motor is 10%. Fine motor, pincer grasp was achieved at 1 year of age. Fine motor, the child achieved pincer grasp at 1 year of age, picks up and dreams form at 1.5 year of age, manages spoon well, scribbles at 2.5 year of age. So the developmental question is 80% for this. And currently the child has lost all fine motor abilities. Social, the child is able to recognize mother at 3 months of age, stranger anxiety at 6 months of age, response to name at 8 months of age, indicate wet pants at 2 years of age, and the child plays alone at 2.5 year of age. Currently, the child does not respond to own name, but the child can recognize the mother. So the developmental question for social milestone is 10%. Language, the child is able to speak 2 to 3 words with meaning at 2.5 years of age. Currently, the child is able to laugh aloud and the developmental question is 10%. So the impression is previously the child was had global developmental delay, now presented with previously lost loss of all the previously acquired milestones. Currently, the developmental question is 7.5%. Previously, it was 65%. Coming to the dietary history, the child was exclusively breastfed up to 2 months of age. The child was started on bottle feeding with cow's milk, diluted with water and sugar. Complementary feed was started at 6 months of age. Family history, there is a younger sibling who is 2 months of age and is healthy. No similar complaints in the family. Socioeconomic history, they belong to lower middle class according to the modified Kopuswamy scale.
And go back to your chief complaints. Yeah, just start all over again, because actually what has happened is you've been unfortunately going in the history to and fro. So we've not got a very clear picture of what the child has come just now with. So you've said that there are some complaints in 7 days, correct? So as usual, our first question is, was this child absolutely all right 7 days back?
7 days ago, he developed rash, fever with rash.
Correct. So
Yes, sir.
before that
Before
fever,
that, before fever and rash, he was completely fine.
completely fine.
Yes, sir.
So
Develop-
exactly.
huh.
So that's a total different issue. So there's a big mix up. So anyway, we'll go into that developmental delay later. So we have a 2.5-year-old child who was developmentally delayed, but otherwise fine. And 7 or 8 days back, he got fever with rash, right?
Yes, sir.
So tell us the details of that fever and rash again. What happened? How many days of fever?
So the child developed this rash 1 week prior to the development of these abnormal movements and
We'll come to abnormal movements later. See, you should give the history like a story. So the history should be okay. For example, 10 days back, this child was otherwise normal. The developmental delay we'll talk about later. So this developmentally delayed child was otherwise normal 10 days back. Then he developed fever. Fever lasted for whatever number of days. Then he developed rash. Then after so many days, he started abnormal movement. This is the way your story should go for a very clear picture, right? So give it to us that way. You know the story, no? You just
Yes.
tell it in your words.
Okay. So 1 week back, the child developed rash in form of multiple this
Fever before rash or after rash?
fever came with along with rash.
So
Fever was associated with rash. On the day of presentation of the rash, the fever appeared, and the fever lasted for 2 days, while the rash continued for 3 to 4 days.
describe the rash.
The rash was multiple vesicular rash, which was discrete. Initially occurred in the oral mucosa.
Inside the oral
Or
mucosa.
inside the oral mucosa.
That was the first appearance of the rash.
Yes, sir. First appearance.
Okay.
Then it progressed to involve the around the mouth, then progressed to involve the hands and the feet.
Hands and feet where? Palms and soles?
Not palms and soles.
Then
on the dorsum of the
hands and feet. And trunk?
Trunk was spared, sir.
No rash on the trunk.
No trunk. But that's also spared.
So what do you think is this rash? Fever and rash?
Could be hand, foot, mouth disease. Because it will involve the trunks mainly, chickenpox. Itching usually it is associated with itching and pleomorphic rash. Different stages will be there. Face is also involved.
So what is pleomorphic?
Rash in different stages, like rash in different stages. Some vesicles will be there, some macules will be there, some will be crusted lesions.
Okay. And itching is a very non-specific symptom. It is there in multiple rashes. It is not there in others. So that's not diagnostic. So one you said is chickenpox rash will be on the trunk as well. What else? What is also not fitting in this story for chickenpox?
Oral mucosal.
Perfect. So chickenpox would not start with a oral mucosal rash. Though having said that, in generally, if there's an exanthematous illness, do you get a rash inside also? In chickenpox, do you get a mucosal rash or no? You can and you do get. So that's known as enanthem. So you will get one or two vesicles inside on the oral mucosa, maybe in the eye, maybe in the ear. Of course, majority on the skin. So you have exanthem plus enanthem. Okay. But it doesn't start with the oral mucosa.
And the eruption of rash. That every day there are new vesicles. Okay, for 5 days it comes on. First day, what was vesicle, next day it is usually not seen as a vesicle because absurd. And then it develops into a scab by day 5. So a rash which has appeared on day 1 gets scabbed on day 5. When rash comes for 5 days, so what has appeared on day 5 gets scabbed on day 10. After that, there is no more. So every day new eruption, as you said, more here than elsewhere, and they undergo this kind of transformation in that. That is why at one stage you will see something is scabbed and something is in the vesicle form and something is not in the vesicle form. That is why we'll call it. So this sequence is important, and one part is after everything is scabbed, they are no longer infectious. So this is not fitting in the chip.
So you said this is hand, foot, and mouth. Okay. Fever and a rash. Then what happened? 2 days fever, 4 days rash. Then what happened?
Then after then after 3-4 days of subsiding of the rash, the child developed this abnormal behavior and abnormal movements of the upper and bilateral upper and lower limbs.
Correct. So now you have to give us a proper description of this. This thing happened all of a sudden. It progressed. It developed over how many days? These abnormal movements.
Sir, this happened all of a sudden. All
Okay.
of a sudden.
And then went on, continued.
It continued. Sir.
So what all happened in abnormal movements?
In abnormal movements, it's involving all the bilateral upper and lower limbs, more on the upper limb, in form of like dance like movements.
Dance like movement.
Like movements. Sir.
Okay.
Also involving the lower limb. Lower limb also has some movement, but some writing movement, sir, but more on the upper limb.
Okay. And what else? That's all. These involuntary movements.
Yes, sir. Just involuntary movements.
So this then lasted. This continued for.
This continued till now.
Till now it's continuing.
Yes, till now he's continuing.
Along with this, any other symptoms?
Along with loss of head, neck control.
Loss of neck control. Then what about hands and legs? So able to walk?
Not able to walk. Not able.
So when did that happen?
Everything happened together on 3 to 4 days after the onset of the rash. Everything happened, but the loss of all these milestones also occurred on the same day.
So see, that's what I'm trying to tell you, that when suppose somebody gets a hemiparesis, will you say he lost the milestone of walking? That's a neurological deficit. You're getting what I'm saying? So don't mix up the loss of milestones. So what I'm trying to ask is that after fever and rash, 3-4 days later, he started with abnormal movements. Till the day, suppose today he had abnormal movements. Till yesterday, was he walking?
No, he was not able to walk.
But you originally was able to walk, no?
No, sir. He was only he had developmental delay before he developed all this. So he was not able. He was only able to stand. He was only able to stand with support.
Okay. Okay. So then, okay, fine. So you are saying that he lost his neck control,
Yes, sir.
right?
Yes, sir.
And he stopped standing?
Yes, sir. He stopped standing also
Okay.
with support.
Okay. Was he conscious?
He was conscious.
Was he eating, drinking?
He was eating, drinking. Even now he is eating, drinking.
No. That day when all these abnormal movements came, was he talking to his parents?
No, sir. Speech.
Originally he was talking?
Yes, sir. Yes, sir.
So,
Originally,
so again, what I'm asking is, suddenly did he lose his speech
yes. Speech also he has lost suddenly.
on that day when he developed involuntary movements?
Yes.
So if I have to summarize, you have a 2.5-year-old boy or a girl?
Girl.
2.5-year-old girl who has been developmentally delayed
Yes, sir.
all along,
Yes, sir.
and now gets a fever and rash which looks like a hand foot mouth disease. 4 days after that, this child stops speaking,
Yes, sir.
loses neck control, and gets abnormal movements
Yes, sir.
and no seizures,
No seizures.
no vomiting.
No vomiting.
Okay. And now after this abnormal movements and all this has started, it has remained the same.
Yes,
It
sir.
has been how many days after that?
Around
From the time it started?
now 8-9 days.
Okay. And there are no new complaints either.
No new complaints, sir.
Of parents smiling, all
Yes,
this
sir.
is maintained. Or,
Recognition is maintained, sir. She can recognize the mother.
and when there are no abnormal or the abnormals all there, when there are no abnormal movements, then the child can move the hand and leg, or there are no such thing like that.
No, sir.
Okay. So now we'll come to this, but because you said originally this child was developmentally delayed, can you now tell us that part properly? Was the birth history normal?
Yes, sir. There is no
Full-term normal
full-term
delivery.
normal
Birth weight?
delivery. Birth weight 2 kilos. 2
Okay.
kilos. Baby cried immediately after birth. There was no NICU stay and was discharged on day of life 3.
So in these 2.5 years, did the mother ever notice that the child is developmentally delayed? They've not sought medical
They
attention
have not sought medical
or
attention.
delayed.
No, sir.
Are there any siblings?
Yes, sir. 2 months old.
2 months old means
Younger child.
just newborn.
Yes, sir.
No older sibling.
No older sibling.
Okay. So now,
Third degree consanguinity.
Yes, sir.
so now first tell us about that. So that developmental delay you've got only through your developmental history. That's right. Mother has not complained of that developmental delay.
Yes, sir. I've got it from the history only.
So give us your developmental history again.
Yes. Gross motor. The child is able to hold the neck at.
No, start from the beginning. Okay, yeah, go on. Go ahead.
Head control at 3 months of age. Rolls over from prone to supine at 5 months of age. Sits without support at 8 to 9 months of age. Crawls at 1.5 year of age. Stands with support at 2.5 year of age. Child.
Stop. So what do you make out of this history?
Till 8 months development was age appropriate, and then the delay had started. Like neck control was achieved at 3 months, rolling over was achieved by 5 months, and sitting with support was achieved by 7 months without support.
8 to 9 months.
So since then the delay had started.
The legs were affected from the beginning, so it got delayed. Stand with support.
So you are saying that the legs have got affected, and that is why there is delay in motor milestones related to the legs. Is that the story, or there is a general delay? So corresponding to this, what was the ability of the child with the hands? How is the the fine motor progressed?
Fine motor, pincer grasp was developed at 1 year of age. Picks up and drinks.
1 minute. All our audience, please mute yourself. Some people are unmuted. Please mute yourself.
Done, sir. Done.
Pincer grasp was achieved at 1 year of age. Picks up and drinks from cup at 1.5 year of age. Manages spoon and scribbles at 2.5 year of age.
So what do you think of this history? Pincer grasp at 1 year, drinks from cup at 1.5, you said, and scribbles at 2.5. It's normal or delayed? Delayed. So if, first of all, we have to verify whether all this history is correct. And if it is correct, it is delayed. So that theory that only the lower limbs are affected is not right. Okay. Now I want you to tell me more. Delayed is fine, but if you are saying it started at 8 months, the delay, what happened at 8 months? Is there an illness that happened at 8 months? Was the baby unwell at 8 months?
No, sir, no such.
So how come it started at 8 months? And the second question is this delay static or progressive? Come on, answer. How do you decide static or progressive?
If the earlier attained milestones has regressed, then we can.
Take these milestones and count. So she said that for gross motor sitting at 9 months. Is it normal or little delayed?
Delayed.
So what would you say DQ? Instead of 100, it would be, let's say, 80. Then next was 1.5 years stand with support. What did you say?
Support.
For that?
Crawls at 1.5 year of age.
Crawls at 1.5 years of age. So what is your normal age for crawling? 9 to 10 months. So this 1.5 years has become how much percentage? DQ. 50 to 60. So you started with 80, then it has become 60. Then you said stand with support at 2.5 years. Normal age is stand with support. 1 year, 10 months, which is now 2.5 years. So this is now what percentage? 30% or even so what is this developmental delay? Progressive. So this is what we are trying to make you understand and ask. This looks like progressive developmental delay with what started off as normal without any event at that time. And then what about the social and language?
Social recognizes mother at 3 months of age. Stranger anxiety at 6 months of age. Response to name at 8 months of age. Indicates wet pants at 2 years of age. Plays alone at 2.5 years of age. Language may the child is able to speak 2 to 3 words with meaning at 2.5 years of age. According to the mother, she said she achieved bisyllables only at 2 years of age. And before that, it was inappropriate sounds.
Before that, you said it was
making sounds like R.
So what are the different parts of language or speech? Receptive and expressive. So what mother is saying is she is talking of expressive verbal language. Now you have to ask questions to find out whether the expressive non-verbal was normal before that. So you are saying mother is saying bisyllables at 2 years or something. But before that, was the child gesturing and communicating? Did you ask that or you haven't asked? No. Okay. Okay. So if you have to go by this, what do you think is the language? Delayed or not delayed? Delayed. So there's global developmental delay, which seems to be progressive, but started normally. When does this happen? You start normally and then get progressive delay without any event. Metabolic disorders. So this history almost looks like a metabolic disorder, and then on top of it, some event has happened now, febrile exanthematous illness, which has led to encephalopathy, where what is the anatomy of your symptoms? What is mainly happening? Involuntary movement. So basal movement. And in addition, loss of previously attained milestones. So there is a generalized involvement, not only basal ganglia, but basal ganglia is prominent. And what is the sensorium of the child now? It's okay. So that means, okay, so we don't know that. So I think few things are not really matching in the history. It's difficult to explain all that, but this is the best we can manage, that what looked like a metabolic disorder, over and above all this has happened. And this illness has kind of speeded up the regression. So this illness has speeded up the whole thing. So we know that metabolic disorders go down with some intercurrent illness. So this illness seems to have brought the child down further. Go on, tell us your provisional diagnosis and then your examination finding.
2.5-year-old female child, first born out of a third-degree consanguineous marriage with global developmental delay, presenting with regression of previously acquired milestones, with acute onset of involuntary movements and behavioral changes, with history of fever with rash. This presentation is suggestive of some post-infectious encephalitis, or autoimmune, could be autoimmune encephalitis, inborn errors of metabolism, or any neurodegenerative disorder.
Yeah, so you're right. Only thing is, like we discussed just now, what happened just now is post-infectious. To call it post-infectious encephalitis, what is not there? What is not fitting in to call it post-infectious encephalitis? Sensorium. That is why we've been asking, what is the sensorium? You are saying the child looks normal. Child is awake, everything is fine. So that is not fitting in with post-infectious encephalitis, so to say. And your further addition of inborn errors of metabolism, etc., is not just the current problem, it is also the earlier developmental delay, which was progressive. Getting my point? If that developmental delay was static, you would have thought it differently. You would have wondered whether there was a event in the perinatal period which led to all that. But that there's no such thing. And that was progressive. So that is why the inborn error of metabolism, if at all, has started much earlier. It has got worsened by the current illness. Right?
On examination, child is alert, awake, aware of his surroundings, recognizes caregivers. Child is febrile, heart rate of 120, RR of 28, SpO2 of 99, peripheral pulses and central pulses was well felt. Extremities was warm. No Fatima.
Tell us your observation findings.
Child is conscious, awake, and aware, seeing around, comfortably sitting on the grandfather's lap, with upper limb, with loss of head control, and upper limb in extended position with lower limb also extended, and involuntary movements of involving distal more than the proximal.
1 minute, 1 minute. This upper limb extended, lower limb extended, this is not correct to say when the child is sitting in the lap and with, all kinds of limb flexion, posture, etc. So all this is to be said when there are no hindrances. So if the child is lying in bed and is maintaining one particular position, then you say that this limb is extended or persistently extended or flexed or whatever. Not this way, right? Okay, go ahead.
With left-sided left ankle CTV is there.
Okay, left ankle CTEV. Then
With involuntary movements of the upper limb is seen.
whenever you are describing involuntary movements, you have to use some adjectives. So what are those adjectives?
Is hyperkinetic or hypokinetic movement?
Means
whether
what?
it is
Which is a hypokinetic movement?
bradykinesia is hypokinetic movement.
Correct. So these, we read all this, but you have to understand also, no? So when do you get bradykinesia?
Only in adult Parkinson's.
Exactly. So in children, we don't get bradykinesia so much. It's only Parkinsonism. So in children involuntary movements, what are the 2-3 things that you will look for and describe when you're describing the movement?
Whether it is involving which limb is involved.
So proximal or distal is one thing that you have to look. More proximal or more distal? 1 second. Rhythmic, non-rhythmic. Third. So what do you mean by repetitive, non-repetitive? What is the meaning?
If it is continuous or repetitive after some interval.
Or the motion is the same while all the involuntary movement, or the motion is changing with time?
Very good. So repetitive doesn't mean that 12 o'clock involuntary movement and 5 minutes past 12 involuntary movement and 10 minutes past 12 involuntary movement is not repetitive. That is, all involuntary movements will repeat only. Repetitive is the morphology, or how in a seizure you talk of semiology. So the movement is exactly the same again and again. That is repetitive. So what is the best example of a repetitive involuntary movement? Chorea is tremors or tics. The same movement happens again and again, right? So that is in the true sense. It's also called stereotype, same or repetitive, right? Then what else? No, what other characteristics you look? So athetosis is what characteristic? Wreathing. Wreathing means what? What does it mean? We use all these words, but we have to understand also, no? What does wreathing mean? Wreathing means twisting or curving. So So this movement is called breathing movement. Okay, but this is not breathing. So this is random, jerky, purposeless. This is chorea. This is breathing. So this is athetosis. Okay, and when you touch and it becomes stiff, that is called dystonia. And there also there's a curving element to it.
Rapid and slow.
And then rapid and slow. So athetosis is not so rapid, whereas chorea is rapid. So these are 4 or 5 adjectives that you should use: more proximal or more distal, rhythmic or not rhythmic, random, jerky or breathing, rapid or slow, right? This is how you describe a movement. So now describe.
There is a generalized involvement. There are multiple types of abnormal movement. So don't get caught and say this is athetosis or this is chorea. That's why the word choreoathetosis. And there could be tremors as well. So you could say that this looks like a mixed type of a abnormal movement, and then say some are like this, okay, some are this way. And therefore, many children who have a disseminated lesion also have a disseminated basal ganglia lesion. Unlike rheumatic chorea, only chorea, right?
So that is a specific condition. That is why you get predominantly coriform movements. But when you get a such a situation like a basal ganglia encephalitis, you'll get all movements mixed, right?
Do you think the head is small or normal?
Small.
Is it important?
Yes.
Why? We don't expect hydrocephalus for the head to be large.
Metabolic.
Of many metabolic or neurodegenerative disorders.
Why should neurometabolic disorders not have microcephaly? After all, why does microcephaly appear?
What is the most common cause of microcephaly? Most common cause, abnormal, that we see in pediatrics. Nutritional.
Yeah, HI.
Better word is injury at birth. So there is a birth injury which is the commonest cause or the most common cause of microcephaly. What sir is asking is a metabolic disorder normal at birth, a child with metabolic disorder, or abnormal at birth? Normal at birth. So the head circumference is normal at birth, right? So therefore,
However, if it starts within a week of birth, then it is likely that it could be little less than normal. Okay, because immediate postnatal period is also a very fast neural developmental period. And therefore, if it has gone past 6 months, then anyway the brain development goes a bit slow and you may have a borderline microcephaly or normocephaly. But anything happening very early could be microcephaly. Now, could neurometabolic disorders have a macrocephaly? Why?
Storage
Excellent.
disorders.
So you can see the whole wide spectrum. Very early, maybe microcephaly, in between a borderline, thereafter normal, and then even macrocephaly, right?
okay. Anything else that you can observe?
Sleeping, are they there or
Movements
not
are
there?
disappear.
Or markedly reduced? One simple way of involuntary movement is first see whether they are rapid or not rapid. That's very easy to find out. If they are rapid, are they rhythmic or non-rhythmic? For example, chorea or tics always may not be repetitive, but tremors are repeated. So you have 2, 3 rapid movement, then you come to slow movement, and then 2, 3 types of slow movements. So it becomes rather simple approach, and rapid and slow is not at all difficult to recognize. repetitive or not repetitive is not difficult.
Any other finding to be seen in the child? Positive finding? You've already examined, so you know. No, means you tell us if anything is to be seen, otherwise we'll send the child out.
No megaly. Tone was normal, reflexes, breaks, sir. And power
Power is
could not be
could not be elicited, but looks normal.
yes.
3/5.
Okay. Okay, fine. ठीक है बहनी जी. Yeah, so now tell us all your examination findings, run through them fast, and then your final diagnosis.
Higher mental function was intact, sir. Cranial nerve examination is normal.
Fundus?
Yes, it was done by the Oftel team. It was normal. Motor tone is normal in all the four limbs. Power more than 3/5 in all the four limbs. Reflexes was brisk, 3+ in right and left ankle on and knee. 2+ in biceps and triceps. Plantar withdrawal task. Sensory system could not be assessed. Cerebellar signs could not be assessed. No meningeal irritation. Spine and cranium was normal. No skeletal deformity.
Any problem in skin?
Any neurocutaneous markers?
Other system appears normal. No organomegaly.
Okay, 1 minute. So you said brisk reflexes, right? What do these brisk reflexes mean to you? Upper motor neuron. So bilateral pyramidal tract lesion. Correct, no? So in this child has bilateral pyramidal tract lesion, you agree? No. Why you don't agree? So pyramidal tract lesion has to have weakness. So whenever you have bilateral all reflexes brisk, but no weakness, then you think twice. This is whether this is pyramidal tract. Usually it is not. So there could be, I mean, it could be non-specific. It could be sometimes in a setting raised ICP and things like that. So be very careful of calling a bilateral brisk reflexes as bilateral pyramidal tract in the absence of weakness.
The bridge could be normal. Okay. And if you don't have a plantar extensor, if you don't have a clonus, you don't expect it. Otherwise, tone is normal, power is normal. Then you would say reflexes are all brisk, but within normal limits. That's it.
Coming to the summary, 2.5-year-old female, firstborn of third-degree consanguineous marriage with global developmental delay, presenting with regression of previously acquired milestones, with behavioral disturbances and abnormal movements, without any visual and hearing impairment, without any seizures and with history of fever with rash. On examination, he has chorioathetoid movements with loss of neck control with microcephaly. Presentation is suggestive of any post-infectious encephalitis, autoimmune encephalitis, Rett syndrome, or immune.
Yeah. So just so that I want to confirm that you have understood what we have been discussing, you tell us what is the problem with your first two diagnoses.
Post-infectious and for autoimmune, the sensorium was intact, so less likely.
And
So,
After HFM,
yes, sir.
what else is not fitting in with the first two diagnoses?
Already global development, already
Exactly. Original global
global
developmental delay is not fitting in. No, you can't give that as your only diagnosis. You understand? So the whole point is that you started with a progressive global developmental delay. That hand, foot, mouth was an intercurrent illness, after which the child suddenly worsened a lot, which happens with so many metabolic disorders. So the role of that infective illness was only to trigger the worsening in a pre-existing metabolic disorder. That is one possibility. And when we are talking of it as encephalitis following that infection, the rest of the story is not fitting in. There are no seizures, there's no raised ICP, vomiting, etc. The child just now sensorium is fine. So to call it encephalitis is a little difficult. So it is just more likely that it was a trivial illness which has triggered the worsening of a pre-existing disorder, right?
investigations. CBCHB was 6.3.
is it likely to be a metabolic disease, or what is in favor of that? Third degree consanguinity, will that be in favor? More like it could be an autosomal recessive disease, since we have no proof of an acquired disease. So among the congenital disease, progressive disease, autosomal recessive, I mean, consanguinity favors the diagnosis of autosomal recessive disorder.
CBC HB was 6.3. Child was anemic. Hematocrit of 20.3. WBC count of 7,000 and platelet of 4,19,000. BBG was done. pH was on normal range 7.37. PCO2 of 31.6. PO2 of 59 and bicarb of 18.1. Serum electrolytes was in normal range. The polar TBL and other OTPT levels were normal. Pancreat level is normal. Ammonia and lactate is also in normal range, and RBS is 128, which is normal. MRI brain was done, which showed diffuse symmetrical bilateral T2 flare, hyperintense signal in the bilateral caudate nucleus, and putamen with no restricted diffusion or blooming on the GRE, no post-contrast enhancement. Above findings with history of fever with rash suggestive of post-infectious etiology, likely viral encephalitis. That's what they've given.
And any other metabolic tests or gene sequencing or anything you have done?
No, sir, not yet, but we're planning to do so.
Okay. How are you treating the child?
Right now, sir, just symptomatic measures we are giving.
The child is the same or getting better or getting worse?
Same, sir. But it has not worsened or it has not progressed, sir. Same.
Anything else you want to say or comment? Or so what is the plan now? Any further investigations are planned, or we just stay put? If it is, if you go by the MRI that it's a post-infectious viral encephalitis, then what have you to do? Nothing. You have to just wait for it to recover.
Previous all milestones were normal. Then actually history was fever, rash, that rash with vesicles, and all the symptoms started. They were telling this head hila raha hai, matlab all titubation जैसे they were telling sir this lost first and could be post infectious cerebralitis also sir. If it was on, if previous development was normal, then that could be the second differential.
Yeah, it could be clinically, but then in cerebralitis, the ataxia is very prominent. Here, there is no prominent ataxia at all. What is most prominent here is the
Movements.
involuntary movement suggesting basal ganglia involvement. So, hypothetically, if it was all normal development and then this history, then because of a predominant basal ganglia, autoimmune encephalitis would have been higher up in a child who was originally normal. But here we are told that this child was not originally normal.
If this move in a 2.5 year old child, sir, ataxia when is not able to walk also, not able to sit without support also, then ataxia we can't tell na sir.
Truncal ataxia can be made. Head to sit, truncal ataxia can be made. Other ataxia though, by chance he reaches for an object, then you know whether he's at the end, whether there is increase. If he's not reaching for an object, no. Truncal ataxia will occur if the cerebellar lesion is the midline. If it is an versa, then you will not. So there are limitations. But often with cerebellar symptoms, there is associated hypotonia, unless there is a superadded hypertonia also.
Many of these acute cerebralitis, they have a raised ICP. So they have those symptoms and alteration of sensorium and all that, right?
I'm just sharing some information. There is a study of all papers on micronutrients in India. And that paper says that more than 60% Indians are deficient in B12, right? And B12 is required for metabolism of fatty acids, which makes myelin. And if it is less, that causes demyelination. So we get peripheral neuropathy, numbness, cramps, and everything. And there is decline in cognition, means brain, every cell brain function. So one dictum is that anything in neurology, find out B12 level, give B12, and if it is less, it works. This is obviously not that, but I just wanted to share it.
Okay. We'll have the second case. Sir.
I think what Hemant said is so important that it's not only B12, but any part of vitamin B. And these are called as a curable neurological disorder. They may come with basal ganglia, they may come with encephalopathy, they may come with behavior disturbance. And I think therefore the routine now is, because B12 is evidence wise, B12 is connected with multiple neurological disorders. And more important is, B12 is common in the community. So if you combine the two, but these are curable neurological disorders. They look like autoimmune or neurometabolic, etc., but you may find surprisingly that they are completely curable. Therefore, it should be a routine. And it's not only that. We know pyridoxine dependent seizure is another example. So it could be any part of B complex, and that is very important, pertinent point he made.
and therefore a routine. We are not much pure of writing tonics, especially our group. But there is place for putting the child on multivitamin right from birth, because of course B12 is heat stable, but some of them may not be heat stable. Mother's level of B12, folic acid, etc., is not known. So it is worth putting, especially in infancy. Child, the commonest deficiency, that is B12, other B group, and vitamin D and calcium are covered up. Anemia also. So that is worth it for our 1.5 year. Yeah. B12 deficiency.
Like for example, if we make India B12 deficiency free, we will get rid of tremor syndrome. If we give them enough calcium, we'll have no children who come with calcium deficiency and fits. I'll just share something more about B12. B12 and folic acid are required for making every cell, and our mothers are deficient. So our babies are born with less number of cells and organs. And when B12 is less, the food is converted into fat. So our babies have more fat at birth than cells. So we are all, that is why we have more fat and we get heart disease and everything at younger age. So it's wise. You all test your B12 and you take your B12, your 10% marks will grow. Do it today. Take methylcobalamin, 1500 micrograms every week, 4 times.
Serum vitamin B12 levels are not dependable. So it's fine that one could look at the macrocytic anemia, but if you want to really prove it, then it's a methyl malonylic acid. But forget about proof. If there is an anemia, mixed anemia, or a macrocytic anemia, then you treat it as B12. Don't waste time in doing a serum B12 level. That does not correlate at all.
Very rarely, if the vitamin B12 is low for a long time, the villi which absorb vitamin B12 are absorbed. And in such rare instances, you may have to give parenterally. But otherwise, giving parenterally, then the villi regenerate. Otherwise, giving parenterally for every child is not this. Also, when you give B12 intramuscularly, some children or adults, it is maybe theoretical, may develop hypokalemia, and therefore first 2 doses are given in a small amount. In an adult, maybe half cc for 2-3 days, and if it doesn't have hypokalemia, then you give the full dose. But perhaps nobody has seen hypokalemia after B12, but it is mentioned. That is why that protocol says that small doses first and later on full doses.
My mother would get cramps, leg cramps, and I would get them. I have asthma. So I would take salbutamol inhaler. So I thought maybe it is because of that. Then I read a book, Is it B12? And he said, any neurological sign or symptom, take B12. I took B12 and both of us became all right. If you eat 300 ml of curds daily, you get enough B12 for vegetarians. And anyone who takes non-veg once a week is a vegetarian. So most of us are vegetarians. And you take it and you will pass in first.
Is heat stable. It is heat stable. So when you boil the milk, etc., it is reasonably stable. But folic acid is not.
No, I'm just reading the book, which I want you to all of you to buy. It says there are only two vitamins which are relatively heat stable. One is B12 and another is folic acid. But how much? Half of it is lost on heating or in hot environment. B12 as well as folic acid.
The wrong impression that it cannot be stored. B12 is a storable vitamin. No.
Okay, we'll have the next case.
Good evening, everyone. I would like to present today's long case. A 3-year-old boy, second by birth order, born out of third degree consanguineous marriage, hailing from Uttar Pradesh, residing from Dharavi, Mumbai, Maharashtra, Mumbai, Muslim by religion, brought by and informed by mother, came with complaints of fever since 10 days, yellowish discoloration involving the eyes and face since the past 2 days, difficulty in passing urine since 2 days, and also there was history of developmental milestones noticed by the mother since 5 years of age. The child has a significant antenatal and birth history and past history. So I would like to start with that first. So antenatal history during the first trimester, mother had history of fever with rash during pregnancy, which on evaluation in a nearby clinic, it was said query varicella and was given symptomatic treatment. There was also history of excessive vomiting requiring some medications. Second trimester was uneventful with iron and folic acid and calcium supplements received. No history of pregnancy-induced hypertension, gestational diabetes, thyroid or bronchial asthma. No history of PRC transfusion. In third trimester, there was history of oligohydramnios in pregnancy, and there was also history of UTI in pregnancy. And there, along with this, there was history of decreased fetal movements as perceived by the mother. For these complaints, she was advised admission for safe confinement. Birth history: the mother was admitted during 34 weeks after she was delivered within 48 hours. The delivery was preterm and LSES was done in view of oligohydramnios. The child had cried immediately after birth and the birth weight was 1.7 kg. There was history of NICU stay for 2 days, not for 12 days, for 2 days in view of respiratory distress, and in that the child had required O2 support for 12 hours. History of neonatal jaundice was there at day of life 4 and which required phototherapy for 48 hours, and the child was discharged on day of life 6 on breastfeeding. Since discharge, up till the age of 5 months, the child didn't have there was no history in difficulty in feeding or sucking, no history of seizures, no history of inconsolable cry, no history of difficulty in changing diapers, no history of fisting, then no other history of any visual or auditory abnormalities. At 5 months of age, child started having intermittent tightening and movements of all four limbs. It initially began with upper limb, left upper limb was more localized, and later it progressed to all four limbs. Child also started having loss of all the attained milestones, such as initially the child used to grasp the mother's hands with both of the hands, but there was in the later on at 5 months there was progressive loss of grasping. There was also a loss of social smile at 5 months of age. At 6 months of age, the tightening movement, the dystonic movement, it was worsening with regression of all previously achieved milestones, such as in gross motor, the child was starting to have some neck control and partial neck holding was present, but later the child had lost that as well. In from bidextrous grasp and fine motor, the child had lost grasping completely, and there was also loss of social smile. And at that time, in view of persistent dystonic movements, the child was started on some medications, baclofen and clonazepam. Then at 2 years of age, the child was again admitted for history of in view of acute febrile illness with worsening of dystonic movements. At this time, there was history of difficulty in passing stools. There was history of urine retention. There was history of feeding difficulty. The child was not taking feeds well. There was regurgitation of feeds. There was history of recurrent cough and cold. There was history of pooling of secretions. The child had also started to require RT feeds, and but there was no history of any visual or hearing problems. There was no history of arching of back. There was no history of any cranial nerve palsy, and there was no history of seizures. At 2.5 years of age, the child had a history of increased irritability during micturition, present with urinary retention and lower abdomen pain. At 2.5 year of age, there was history of two previous admissions in view of UTI with urine culture suggestive of E. coli and enterococcus, with child receiving IV antibiotics for 14 days. Coming to present illness, the fever was high grade, undocumented, associated with chills, with no rash or rigors. intermittent, relieved with medication. Yellowish discoloration, which involved the eyes, sclera, initially with later extending to involving the face and body, associated with passing pale colored stools with one episode of black colored stools. Child was not passing urine since 2 days with lower abdomen distension, which was drained by intermittent catheterization. And at that time, around 100 ml of urine was passed, which was dark in color. Family, the child also has a significant family history of cerebral palsy in elder sibling with similar presentations, as who is the elder sibling is now 8 years old, and he also had similar history of presentation. But at that time there was no history of there's no history of previous loss of any milestones. And 3 years ago the mother also has a history of intrauterine fetal death at 8 months of gestation. Developmentally, the child currently has loss of head control, no spontaneous smile, but there is auditory and visual milestones where the child startles to sound and closes eyes to torchlight. So my impression of developmentally, the child is having global developmental delay. Dietary history when the child is on RT feeds, and child is immunized till 1.5 year of age and belongs to lower socioeconomic class as per modified Kupuswamy scale. To summarize, 3-year-old boy, second by birth order with third degree of consanguineous marriage, came with complaints of fever, yellowish discoloration, and difficulty in passing urine. With history of previous history of UTI, with history of delayed milestones, with a significant antenatal birth and past history, with a positive family, with previous history of urinary retention complaints, and with history of cerebral family history of cerebral palsy in elder sibling, is um, most likely a case of cerebral palsy presenting with urinary retention. Which cause of cerebral palsy could be either antenatal infection or hypoxic or any genetic cause.
Can you just go back to your presenting complaints? First, we'll discuss this fever since 10 days and yellow discoloration since 2 days. So, how would you think when you get this history in anybody? Come, you sit here. What are your initial concept thoughts when you get fever for 10 days and then yellow discoloration for 2 days?
Viral hepatitis.
So anybody wants to discuss whether it can be viral hepatitis or it is unlikely if you get this history? What is the classic history of viral hepatitis?
Vomiting and anorexia are the presenting complaints. Fever may or may not be.
Hold close.
Fever may or may not be there, but gastritis, vomiting and nausea should be the predominant complaints.
So
for
vomiting,
viral
anorexia is very, very prominent. One. Second, for viral hepatitis, I'm saying.
There's usually fever will subside.
Okay, fever subsides and jaundice comes. But in what's the timeline? Means can you have fever for 10 days, 15 days and then jaundice?
No.
How long? You're almost there. You picked it up perfect.
22 hours.
Yeah, 3-4 days, 5 days, max 3-4 days actually. So all this is missing in this history. So we will say that this does not look like primary viral hepatitis at all. It is something else. Now you got jaundice for 2 days, right? Suppose you go back 2 days back, then you had only fever for 8-9 days, 10 days, whatever. So what would you think of then? 8-9 days of fever only.
Could be enteric.
Could be enteric fever, very good. So you look for the details of the fever. So what are the details of the fever?
Fever was moderate, high grade. It was associated with chills. It was intermittent, and there was partial relief with medications.
Over these 8-9 days, was it worsening, rising trend or no rising trend?
Same. Over the 8-9 days, the course was the same. It was not worsening and not subsiding.
Any other symptoms along with that?
Um, Only 1 to 2 episodes of vomiting was there, and in the history of passing, 1 to 2 episode of loose stools and 1 episode of black colored stool.
What do you make out of that?
If we consider the other complaint of difficulty in passing urine since 2 days, we could think about urosepsis, which could have led to hepatobiliary involvement, which then leads to uh, biliary radical swelling, and then there is a component of biliary obstruction.
So what do you understand by difficulty in passing urine? We have a 3-year-old child, right? Right? What is the meaning of the word difficulty in passing urine? Means what?
Either the child must be having burning during micturition.
So we need to find out that what does the presenter mean by his difficulty in passing urine. So what did the mothers?
The child was not passing urine since past 2 days, and there was also mother had noticed progressive distension at the lower abdomen.
So this
history of straining was there.
So this history is almost suggestive of retention of urine, right? What I'm trying to say is, first of all, that difficulty in urine has to be clarified what it is. This history suggests retention. So there's no way this history suggests infection. And remember, whenever we talk of urosepsis is a problem of very young infants, and they would not come with urinary complaints. They would come with fever. Clinically, their problem would be fever and whatever, very high fever, sepsis like vomiting, sick child, etc. Right? Here, you had fever for 8 days with very vague other symptoms, and then 9th day jaundice, and then difficulty in passing urine. That infection is not the connection, right?
I think one important point in every fever is to see how does the child look like when the temperature comes down temporarily. And I think that is very important. If this child has 8 days of fever without any other symptom, then it could be a non-localizing infection. But in that case, the child is getting sicker and sicker, like in typhoid fever. So we need to look at all that. If child is reasonably fine in between fever episodes, then infection is most unlikely. And if infection is most unlikely, then you move towards immunological disorders or maybe malignancy or whatever. So we need to be little clear about all that. But at this point of time, the presentation is a prolonged fever with followed by jaundice. Now, obviously, infection looks most unlikely in terms of viral infections. But could it be an enteric fever coming out with hepatic involvement? Yes, provided we get the story of fever like a bacterial infection. Could it be leptospira doing it? Leptospirosis could also have an immune mediated hepatic as well as a renal. Okay, but these children come with failure more than infection of the liver or infection of the kidney. So it's an immunological fever. So that we need to look at that. Now, when you talk about retention of urine is still proved otherwise neurological, but it could theoretically be some obstruction beyond the bladder neck, and that doesn't happen in children. But theoretically, if there are some blood clots, maybe because you said some high colored urine, so is it some blood in the urine which has stayed inside and has developed a obstruction by blood clot? Then possibly you may have a retention of urine. So I think infection, urinary tract, not primary. Jaundice, not infective probably, but if we get all the details of fever, we can be sure non-infective or infective. But to begin with, we would say non-infective hepatic disorder. Okay. Now, when it comes to retention of urine, we don't know how to connect the two. So the question is, there is some delayed development also. So is it anything syndromic where there are multiple malformations and those malformations are also responsible for some complications? I think you gave a good history. Okay. But learn also to give little more details of each symptom, like fever in particular. But otherwise, it was a complete good history. So at this point of time, we are not sure how to take all those delayed development plus a delayed jaundice after 8, 9 days of fever, and then the retention of urine looks little incongruent in terms of putting into one figure. So maybe there are multiple issues. You have a developmental delayed child and now he's developing something else. But even if you say fever, jaundice, and retention of urine, that also doesn't go together. So we are quite surprised with this. The point I'm making is your history may be right and good, but when it doesn't fit in our one track of thought process, we must get back to the mother and ask many more details. Then we might find something different. For example, has this child grown well? Imagine this child has got a renal malformations, chronic renal dysfunctions, then he is not growing well. Not only his weight is low, but even his length is low. Okay, so all that might tell us whether he has got primarily some chronic renal malformation, now add to infection, whatever. So I think this is the way we may analyze.
Now, you said there was first trimester some fever with rash in the mother, and then you said the neonatal period of the baby was stormy, had to be in NICU and all that. Now, explain this or postnatal history. So, you've said there is loss of previously achieved milestones by 6 months, but what was achieved? So, was the baby normal for the first 4 or 5 months?
Yes, for the first 5 months, the child was normal. He was, the parents were not, have not seen any signs of any delayed development or any developmental.
Agreed. What I'm trying to say is that were you able to ask and confirm normalcy in the first 4 or 5 months? How would you ask that? Means what all would you ask? Was this there? Was this there? Was this there? And parents said yes.
Uh, for I had asked for the neck control, neck holding. So the mother was saying the child was trying to hold neck while eating. Then and at that point, I was also asked for how the child used to grasp an object. So with both hands, the child used to reach out for objects. Then the mother, he recognized the mother and smiled. There was history of cooing by 3 months of age. Then at 6 months of age, when the child started having this abnormal tightening movement of the limbs, there was also the child also beginning started to begin to lose the grasping, and later on with grasping, the neck holding was also lost. and smile, also social smile was lost. The child used to look at mother, but he there was no smile. And language, only the child used to babble, and still he only babble. At 2 years of age, there was history of hospital admission for acute febrile illness, which were with worsening of dystonic movements. And at that time, there was history of difficulty in passing stool. There was history of urinary retention. There was history of feeding difficulty. There was history of pooling of secretion. History of recurrent cough and cold. With For the feeding difficulty and pooling of secretion, the child started to require RT feeds, and but there was no history of any vision or hearing problems, no history of cranial nerve palsy, no history of back arching while feeding, and no history of seizures.
Again, this 2 year thing, history of difficulty in passing stool and urinary retention, again suggests some neurological issue at that time. So, was there any the paucity of movement or any other complaints at that time to suggest a neurological issue at 2 years?
Only the dystonic movements, which was there, it was worsening. Yes, it was there since it had started since 5 months.
In the newborn period, baby needed resuscitation.
Uh, yes, there was yes, the child had required NICU stay and required O2 support.
No, but resuscitation immediately at birth.
No, no.
So NICU was for what?
It's for low birth weight.
No, what I'm trying to drive at is, what do you think is the cause of this dystonia coming up at 6 months of age? What is the possible reason? Again, like the previous child, we have to think of, so one, there seems to be a very definite history of regression of achieved milestones on one hand, and then what do you think is this dystonia due to? So again, it's a basal ganglia involvement. Now, many birth injuries would come up with symptoms related to basal ganglia. You have chorioathetoid CP, dystonic CP, etc. But then that interval period is not fitting into that birth injury. The child seems to be absolutely normal for those 3-4 months, and then all this has happened. So again, whether this is a neuroregression as a whole thing, that's the point.
I think if dystonia came up suddenly and also it stopped thereafter, then it could be a drug induced. And the common drug antiemetics. Now this could have had
stopped. It was only
it is
worsening.
persistent.
It is persistent.
If it is persistent, then it's the same problem of what has caused a sudden drop in the milestones. And I think we leave it at that. But when you talk about constipation and retention of urine, but you also said something feeding difficulty also. Feeding difficulty also. So I think that together could be only neurological. Okay. But if it was only constipation and possibly retention of urine, I wonder whether this was any hypokalemia, hypomagnesemia with constipation, and many times constipation could be causing a urinary obstruction as well. I mean, we are just trying to consider everything into one area, but we are not sure about that. Let's see, on examination we will know. But what happened thereafter? Anything specific to tell us for analysis?
After that, at 2.5 years of age, there was a history of two admission for urinary retention, and along with that, there was also history of UTI with child requiring IV antibiotics. There was a significant family history with elder sibling also having cerebral palsy. and history of IUFD, intrauterine fetal death in mother. Yes, similar.
Family history. So one strong point against cerebral palsy is family history. So you're right. Family history of delayed milestones.
So what happened to that elder sibling?
He's currently he's alive and well.
No, so what is his complaint?
His complaints was also this delay. He also complained of delayed milestones. Initial presentation was of delayed milestone. No. He does. He didn't
This
have
is
any
the
history.
elder sibling I'm asking. Elder sibling, what is the complaint? So delayed milestones which
milestone.
are getting better or
No, it remained. There was no further progression of any new milestones.
and so what's your provisional diagnosis in this child?
My
Summary.
A 3-year-old boy, second by birth order, born out of third degree consanguineous marriage, came with complaint of fever, yellowish discoloration, and difficulty in passing urine, with a history of delayed milestones, with significant antenatal birth and past history, with positive family history, and history of global developmental delay in a partially immunized child, is a case of most likely a case of cerebral palsy with with acute urinary retention.
Yeah. So for cerebral palsy, what is very important is one, we should be able to sort of convince ourselves that this is static delay, right? Whereas you have given a history of regression of milestones. Achieved milestones have gone down. So that is not seen in cerebral palsy, right? So we will not use the word cerebral palsy unless there is some mistake in our history only. We'll see. Come, tell us the examination point. This child is there, no? Come, let's see the child.
The history of oligohydramnios during the ANC period, should we consider that significant? Because urinary complaints are many times the child is presenting with urinary retention, and during the ANC period also the child was delivered 1.7 kg with history of oligohydramnios. So can there be a urinary system, genitourinary system involvement since birth?
So involvement, yes. So two, three things. One is, see, oligohydramnios is a very common and a very non-specific finding. It doesn't give you a cause and effect relationship. That is one. Second, you want to think of a urinary abnormality because of oligohydramnios, but what kind of urinary abnormality? So if there is a malformation of the renal system, the clinical symptoms are not urinary retention. You get my point? So, urinary retention is different from poor formation of urine, is different from polyuria, is different from urine infection. So, we can't club urinary complaints as one thing and relate it to oligohydramnios. You understood what I'm trying to say?
Of urine is lower tract symptom, not upper tract. Unless there was oliguria, which was interpreted as retention of urine. Okay. And then they had to catheterize and remove surgery. Recurrent urinary retention has to be either autonomic but lower tract problem.
But you can see. Right?
So the child is irritable. The child is irritable. Right now, there is a twisting movement of both the upper limbs. Then neck control is not there.
Is he aware of his surroundings?
No, sir.
Try ask the name and call out the name. Check means it looks like he's not aware, but
Lee. Ali.
okay. Then doesn't seem to be aware. Then what else? So comment on growth, comment on any
So the
paucity
child,
of limb movements.
so the child is poorly built. Or no.
आप अगर उसको जल्दी से ऐसे नजदीक से देखते हो तो आपकी नजर को नजर मिलाता है, आंखें ऐसी 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 घूमती रहती है।
Sir, there is no paucity of movement. All the four limbs are equally mobile. The child is able to move all the four limbs. But in both the upper limbs, there is some involuntary movement of the distal muscles.
Cranial nerves, lower cranial nerves swallowing. He's drooling, he's frothing, he's not able to swallow. When the mouth was open, I could see little pulling of secretions.
What is the position of the hands and of the feet?
The hands are externally, the right upper limb is externally rotated due to
So when we say hands, we don't mean the upper limb. So I'm telling you to focus on the both the palms and both the feet. What is happening at the wrist and at the for the fingers, thumb, etc.
so there is flex, dystonic kind of movement on the at the wrist joint.
So dystonia will be twisting. His wrist joint is continuously in a spastic position, right? And he's most of the times his thumb is across his palm as if it is spastic. So there seems to be hypertonia. Look at his ankles. Both his plantars are plantar flexed. I mean, his soles are plantar flexed. He has nothing obstructing him there. So why should he keep his foot down? Understood? So contrary to the previous child where I said don't talk of posture, the legs are free yet both soles are going down. So this might be hypertonia or spasticity.
Just quickly. Fine. I think he can tell us the findings.
quickly tell us all your findings and then your.
Uh, in general examination, on general physical examination, on examination, the child was afebrile and irritable and not interacting with surrounding. Her heart rate was 124 with RR of 30 and saturation of 98 on room air. Peripheral pulses were well felt and extremities were warm with pallor, icterus, and pedal edema present. On anthropometrically, the child was weight 10 kg, which was between -3 to -2 standard deviation. Height was 92 centimeter, between -2 to -1 standard deviation. Head circumference was 44 centimeter, less than -3 standard deviation, and mid upper arm circumference was -1 to 0 standard 14.5, which was between -1 and 0 standard deviation. And weight for height fell under less than -3 standard deviation. The child was severe falls under severe acute malnutrition. On head to toe examination, there was microcephaly with large ears and oral ulcers and dental caries. Systemic examination with child was irritable and not interacting with surroundings. Position was flexed. And the child was examined in supine position with flexed upper and lower limb. And pupils were both are equally reactive to light. On cranial nerve examination, there was squint present in left eye. Other than that, there were no signs of any other cranial nerve abnormalities. There was tone of increased and variable spastic tone was there. In upper limb, it was there more than the lower limbs. And power was 3/5. And in reflexes, knee and ankle reflexes were brisk, and rest were reflexes were normal. And there was no clonus and no meningeal signs was present. On per abdomen, it was soft and non-tender with flank dullness present and liver palpable 4 centimeter below costal margin, and spleen was not palpable. Respiratory and cardiovascular examination were within normal findings. To conclude, 3-year-old boy, second by birth order, born out of third degree consanguinity, with complaints of fever, yellowish discoloration, and difficulty in passing urine, with history of delayed milestones, significant antenatal and birth history in partially immunized child, with examination findings suggestive of microcephaly with SAM, and CNS examination suggestive of dystonia with re- um, with decreased power in all four limbs and brisk reflex, is a case of uh, cerebral palsy with acute onset of urinary retention, which could be due to which leading with which could be due to urinary tract infection or and hyperbilirubinemia secondary to either viral etiology or drug intake.
Go ahead, tell us the investigation findings.
So investigations, CBC was done. It was hemoglobin of 8, platelet of 20, hematocrit of 24. There was leukopenia. Total cell count was 3,900, and there was thrombocytopenia. A platelet count of 95,000. Liver function test. There was total bilirubin and direct bilirubin was elevated with 12 and 10, and OTPT was liver enzymes were also deranged with 3,200 OT and 2,400 PT, and RFT was also more showing pre-renal AKI picture with BUN of 29 and creatinine of 0.8. Other viral markers were for dengue, lepto, and malaria. It was negative, and for Hepi was also negative. USG was suggestive of mild ascites, and with normal KUB, and with no increased bladder wall thickness. Urine culture was urine routine was 8 to 10 pustules with bacteria present, and urine culture was suggestive of E. coli. Previously, the child was for these complaints, previous investigations at 5 months of age, the child was evaluated. At that time, MRI was done, it was suggestive of cerebral atrophy, and EEG was suggestive of, not suggestive of any epileptiform activity. And later, at 2 years of age, there were genetic testing was done for this dystonic movement. It had shown genetic mutation for dystonic cerebral palsy.
So, two things. One is Amdekars sir already made a point that cerebral palsy is not familial. So, when you get more than one child in a family with what looks like cerebral palsy, it is a genetic disorder and not something to do with birth injury or otherwise. So, that is itself your clue that this is a genetic disorder. And second, in dystonic cerebral palsy gene that you are talking of, I don't know if they are initially normal, as in, have you read up whether that initial period of normalcy is explained in that? We'll have to check that because to call it a genetic disorder like a dystonic cerebral palsy, you are saying that initial period of 6 months normal, then milestones regressing, that's a little unusual, right? So you have that genetic report exactly what it was, dystonic cerebral palsy, you're saying.
Pathogenic variant was detected.
Fine. And so according to you, the current fever and jaundice is a viral hepatitis.
We initially suspected viral,
Cold
but
close.
we initially suspected viral cause, and we evaluated also for the hepatitis virus, but it was negative. So later we were suspecting that it could be drug related. So we stopped all the possible hepatotoxic medications for the child, and later the child had responded to the management.
So the jaundice got better.
Jaundice got better, and also the liver enzymes were within the falling trend.
And what happened to the fever?
Fever also responded to antibiotic treatment. Yes, we treated it as UTI.
Okay.
On presentation.
Enzyme derangement. You are considering drug induced. That I want to know.
He was on drugs before the
He was
illness.
He was on medications for dystonia.
Okay. Fine. Any questions? Anything from the online audience? Any comments or questions from the online audience?
Yes, sir. I am unmuted.
Okay.
Rajesh, for me, it looks like mostly, as you told, it's a genetic disorder with normal development and regression starting by around 5 months of age with the stiffening and everything. So looks like mostly this child and that child also would have had the same thing.
Yeah, correct.
Something.
Yeah. Fine. Anything else? Any other comment?
Rajesh, the other possibility, of course, this child has had a genetic workup, but whether tyrosinemia with such severe liver involvement should be hepatorenal, consideration.
Yeah, only thing is age-wise, it has happened much
Too late.
later.
Yeah.
Yeah, so that's
Yes.
the problem.
Yeah. But excellent presentations by the students, and thank you, Amdekar sir, Rajesh, Dr. Khare, and all online faculty, and all those who attended. Thank you, Hemant and Archana as well.
Thank you. So we meet next Thursday at 5 p.m. Thank you. Bye.